moving along to another organ, we're going to talk a little about the liver now. There have been associations with protease inhibitors causing liver toxicity. Now, again, some more than others. You'll see taprenavir as well as high-dose Norvir often implicated with liver abnormalities, but certainly can occur with other protease inhibitors. Some of our patients, even they may not even notice that they're having liver complications, so maybe asymptomatic, especially early on, where certainly the liver is still functioning fairly well. However, when you do their lab work, you might see, that's when you see elevations in certain lab parameters, so ALT, AST, bilirubin, as well as alk-phos. Now, when patients who do present with symptoms from their liver effects from the medications, they may have things like jaundice, so again, yellowing of the skin, they might see yellowing of the eyes, they feel sick or malaise, nausea, vomiting, which is very nonspecific, as well as anorexia. So there can be symptoms. Now there's one drug that you have to keep, two drugs, that you have to keep in mind that even though you might see yellowing of the eyes or yellowing of the skin and perhaps even elevated bilirubin level, it may not necessarily causing liver toxicity. So what I'm talking about here is atazanavir and indinavir. Both of those drugs can cause an indirect hyperbilirubinemia. Basically, it's an elevation in bilirubin. And these two drugs affect how bilirubin is conjugated and eliminated through your body. Well, patients, again, might have this. The bilirubins might go up in the lab when you check their blood work, but their other enzymes, their AST, their ALT, alk-phos, may all be normal. And again, these patients, if the bilirubins go high enough, they may still have symptoms like the yellowy eyes and the jaundice. However, it's important to not be alarmed by this because it's not a side effect that's really causing major damage. It's not causing damage to the liver. So you have to calm the patient down, let them be aware of it. Certainly, we don't manage it any differently. We continue the patient on that particular regimen. And certainly if it becomes an issue in terms of cosmetic issue where it's going to affect their adherence, and that does come up sometimes where patients are not willing to use the medication because their eyes are yellowish. In that scenario, that might have complications on adherence, in which case we would need to make a modification to the regimen. So now, before you decide that a particular drug is causing the liver toxicity, you always have to rule out other complications. So there are certain viruses, hepatitis B, hep C, and various other complications that can cause liver toxicity in addition to the drug. So once you rule out these other problems, then you can implicate possibly the drug. Now again, depending on the severity, you may need to discontinue the therapy and then switch to an alternate therapy once the resolved.
So let's talk about bleeding and adverse effects. One of the drugs, taprenavir, I actually said it right, didn't I, for a generic name, is activist. Actually has reports of intracranial hemorrhaging. That's like a hemorrhagic stroke. So the way you would do that is a black box warning. So we wanted to bring that up for everybody tonight. You would manage it by taking the patient off after this, of course, and then give them ICH supportive care. Also, protease inhibitors can be associated with increased spontaneous bleeding in hemophiliac patients. That's bleeding into the joints, muscles, and soft tissue. So be cognitive of that. The way you would manage that is consider switching to a non-PI regimen or may require increased use of factor VIII products.
So osteonecrosis, again, this is another side effect that really doesn't happen too often. It is rare, but it's been linked to some of the older protease inhibitors. It really is not clear as to whether it's caused by the antiretrovirals or is it the HIV or is it something else. There are certain risk factors that are associated with osteonecrosis, and they include diabetes as well as advanced HIV, having been on prednisone or steroids for a very long time, the elderly, alcohol use, and as well as elevated lipids. Now, when patients have osteonecrosis, the thing that they complain about is pain, excruciating pain, to the point where I've had patients who come to the clinic where they cannot even walk without some assistance. You know, they might come in a wheelchair, they might have a walker. Again, it's debilitating type pain. Now, how do we manage it? Of course, is we will often use pain medications, so some of their opioids like morphine, OxyContin, Percocets, you might use ibuprofen in combination with them. We'll always have the patient try to reduce any weight bearing on that affected joint, so again, trying to use other devices to help support their joints. Really, the ultimate solution to the problem is a surgical procedure. So some patients who may have, like for example, avascular necrosis, osteonecrosis of their hip joint might have to see an orthopedic surgeon to have that hip replaced. Now, surgery on an HIV patient is a whole new, story, because some of our HIV patients, their CD4 counts may be too low for them to be a surgical candidate. So, one of the big things we worry about after having surgery is them being able to heal. And if your immune system is not up to par, then they're going to be a high risk for surgical complications after the surgery, including infections. So some patients may actually have to, unfortunately, wait it out, start them on the medications, get their CD4 count high enough, manage their pain until then, and until they can actually go to and have that surgery done. And I do know a few patients who had that, and after their surgery, they're just so much.
So some of the drugs actually have a sulfur component in part of their structure. So this is especially true with you pharmacists. Your drug screening, your allergy screening programs in your pharmacy systems may actually bring up Persista, Lexiva, and Activus for the sulfur allergy. It is not contraindicated. You can actually use these medications with patients with sulfur allergies. However, proceed with caution, and you just might want to contact the physician, make sure that they're aware, so they're cognitive of it, but you can use it in patients with sulfur allergies. I want to make sure y'all use that just in case you got red flagged in your computer system. So also with the protease inhibitors, Lexiva, Persista, and Activus, they could also have a skin rash that develops. I promise you'll always be on a Saturday night when the physician's not around. So when you're evaluating a patient, you need to decide what the rash is. Is it a very mild or moderate rash? Is it consistently getting worse? Did it just show up? How long have they had it? All these things come into place. Now, they can develop into something a very serious rash called the Stevens-Johnson rash, which looks like a burn patient, and you never want to develop to that. But if it's a very mild or moderate, you usually can treat through it. So make sure that you coordinate with the physician. You call them, and you make sure that on Monday, if it's on a Saturday night, you coordinate with the physician to make sure that everything's kosher and okay. But if it's getting really worse and worse and worse, you may have to tell the patient to not take the medication. So you really have to just be cognitive of it.
Breakaz or atazanary, in addition to the hyperbilirubinemia I mentioned, it can also cause a prolongation in the PR interval. So this is something that you can see in an EKG tracing. And it's not to the point where we do much about it. It won't go to a third degree AV block or second degree. It's usually very limited extent. However, just keep in mind that there are other drugs that can also increase PR intervals, like beta blockers and certain calcium channel blockers. So now with Crixivan, one of the big things with Crixivan is it can cause kidney stones. This is especially important during the summer, of course, and any time when the patient's going to be overexerting themselves and potentially becoming dehydrated. So it's very important that we counsel them about kidney toxicity. And the way you manage it is that they have to drink plenty of fluids. That's why that big auxiliary sticker that we stick on Crixivan bottles is very important, and the patient does do what it says. It says take plenty of fluids. Usually means at least 1 liter to 2 liters of fluid throughout the day. However, in addition to the kidney stones with Crixivan, it can also cause a few other things, including hair loss or alopecia, ingrown toenails, as well as dry skin, and sometimes I've seen people have nosebleeds. So it's not a drug that's generally used first line. However, you will see patients who've been on Crixivan for years and they've done fine, and their viral loads have been undetectable, and they don't want to make a change. Well, you do have to still warn them about the kidney toxicity. And in fact, the kidney stone is it's the drug itself that precipitates in the kidneys.